Welcome to the first Cleveland Clinic Tumor Board. This is Dr. James Abraham of the Taussig Cancer Center of Cleveland Clinic. Today, we'll discuss the management of locally advanced HER2-positive breast cancer. We have Dr. Calhoun from pathology, and we have Dr. Shepherdson from radiology, and we have Dr. Grobmeier from surgery, Dr. Tenelker from radiation oncology, and Dr. Moore from medical oncology. So in addition to the panelists here, we have Dr. Terry Maimunas from University of Florida and Dr. Mikhail Sakaris from Cleveland Clinic joining us remotely to discuss this important topic. So let's start with the patient. Haley.
This patient is a 39-year-old premenopausal woman who initially presented with right breast pain to her primary care provider. She had a past medical history of migraine and hypertension, and also a history of hyperlipidemia. She had a family history that included breast cancer in both a maternal and a paternal great aunt, and colon cancer in her paternal grandfather, with no other significant cancer history in the family. On examination, she was found to have an approximately 4 centimeter palpable mass in the right breast, and at the time of her presentation, no adenopathy was appreciated in the axillary or supraclavicular regions. She was referred for diagnostic imaging, which I believe Laura has.
She presented for a diagnostic mammogram. The Beakley marker on the skin in the right breast overlies the palpable abnormality that was detected on physical exam. It also corresponded to her focal area of pain. She has a diffuse area of pleomorphic heterogeneous calcifications extending from the nipple all the way posterior to the chest wall, as circled on these images. The image that I'm showing you now is a tangential mammogram image of the palpable abnormality, which shows her palpable abnormality corresponds to the large area of pleomorphic calcifications. We took her to ultrasound because she did have a palpable abnormality. There was a large, irregular hypoechoic mass at the 1 o'clock position, which had multiple focal echogenicities within it, which corresponded to the calcifications we identified on the mammogram. This mass measured approximately 4 centimeters on ultrasound. She also had an abnormal lymph node in the right axilla, which had irregular cortical thickening. We then took her for an ultrasound-guided core biopsy of the mass, presented here. The top picture is the pre-biopsy image. The bottom picture is the post-biopsy, and this shows the clip within the area of the mass. She also had an axillary lymph node biopsy at the same time. This particular mammogram was done after the biopsy. It shows the clip in the upper inner right breast. That is where the biopsy was performed in the area of the calcifications. She then went on to have an MRI. These two images are an axial is the top image. The bottom image is a sagittal picture of her breast. You see a large area of irregular enhancement in the upper inner right breast and a second area in the inferior part of her right breast. On these particular images, the top 2 images are fat subtraction, axial and sagittal images that are post-contrast, and the bottom 2 images show us the kinetic enhancement patterns. You see in this first mass in the upper inner right breast, which is what was biopsied, there is an irregular mass with heterogeneous enhancement, circled here. And then there was also, at the 6 o'clock position, another irregular mass, which also demonstrated heterogeneous enhancement.
And Laura, was the second area seen on the MR biopsied?
No, it was not biopsied.
And your suspicion of that being related?
It was pretty high.
Pretty high.
Yes, just based on the enhancement characteristics, and it looked so similar to the index mass.
And then when you see this, it's kind of natural for you to do an MRI at that point, or
Well, the MRI was done after the biopsy, so we had confirmation of the diagnosis.
Right.
So because she was in new breast cancer, she had heterogeneous, actually extremely dense breast. The extent of the disease, her age, being younger than 50, we recommended that she have an MRI.
And also, James, in patients who have large tumors who, from the beginning of their evaluation, we think might be candidates for neoadjuvant therapy.
Right.
We, in our practice, use MRI as the tool to assess response to neoadjuvant therapy.
Right.
In addition, we like MR in younger patients because it may pick up occult cancers in the other breast that we otherwise wouldn't know about.
Right. So strong family history, young age, dense breasts, neoadjuvant treatment, right, okay. And multifocal disease probably you're trying to do, right?
Yeah.
Right, okay, right, good. All right, okay. The patient had the biopsy and
Thank you, James. So I'll discuss the pathology findings as well as the hormone receptor and HER2 testing that we performed in this case. The core biopsy from the right breast showed an invasive ductal carcinoma, nuclear grade 2. Both estrogen and progesterone receptor immunohistochemistry studies were negative. A fluorescence in situ hybridization study for HER2 gene amplification was positive, with an average HER2 gene copy number of 20 and a ratio of 11. The concurrent right axillary lymph node core biopsy was benign. This is one representative image from her core biopsy, just showing a high magnification view of an invasive ductal carcinoma, no special type. And this is one image from her estrogen receptor study showing the hematoxylin stained nuclei so that we're able to confirm that tumor cells are indeed there that are negative. The image in the lower right corner is an example of how we would evaluate internal controls in a case like this, showing a benign lobular unit with variable staining for estrogen receptor. This is an image from her FISH study for HER2 showing red signals, which I believe you can see in abundance in the background of the DAPI stained nuclei. That's the probe for the HER2 gene. The probe for chromosome 17 are the green signals. In most of these nuclei, you can see only 2 of those. So this is a strongly amplified case.
so Ben, you went to FISH.
That's correct.
So, I mean, what's your thought about FISH versus IHC, and why we are doing FISH straight away? And
So both in 2006 and in 2013, the ASCO-CAP expert panel concluded that one could use either testing algorithm for HER2, meaning that you could start with immunohistochemistry and use FISH for equivocal cases, or that you could primarily test with FISH and then reflex test by immunohistochemistry for equivocal cases. Probably the most common testing algorithm used is primary immunohistochemistry followed by FISH. Here we have used primary FISH for a number of years and have a lot of experience with that. So the biggest change in the HER2 testing guidelines that we've seen recently were issued in 2013, and there were changes both for immunohistochemistry and in situ hybridization testing. The change for immunohistochemistry was to revert to the old threshold of greater than 10% positivity to call a case 3+. That was what was in the original package insert from the first FDA-approved assay in the initial adjuvant trials for Herceptin therapy. That was then raised by the expert panel to 30%, and now it's back down to 10%. The other change in HER2 FISH testing was an emphasis on HER2 gene copy number. We use a 2-probe assay here, and we've all learned through our experience with the control probes for chromosome 17, there can be issues with the copy number that can affect the ratio. And so an emphasis on assessing HER2 copy number helps us better determine who might have true gene amplification. The criteria that I mentioned for immunohistochemistry are that for a case to be considered 3+ positive, we need to see complete, intense circumferential membrane staining in more than 10% of the invasive carcinoma cells. And one of the things that's important, whether you're doing immunohistochemistry or FISH, is to make sure you're analyzing the invasive carcinoma cells. Ductal carcinoma in situ is very often positive for HER2 or shows HER2 gene amplification, and you could easily generate a false positive by studying the wrong area. So the equivocal range, as you alluded to, has changed a little bit for FISH in that ratio of 1.8 to 2.2 is no longer considered equivocal. We've reverted to the 2.0 or greater threshold with a few caveats about HER2 gene copy number that would indicate the need for potential repeat testing. And the scoring of negative cases has not changed. For immunohistochemistry, 0 or 1+ are both grouped together as negative. And for FISH, any case with fewer than 4 HER2 gene copies per nucleus and a ratio of less than 2 is considered negative. These diagrams just briefly go over the algorithms that we've been discussing. One thing that we could emphasize at the bottom of the panel is that there's a requirement for equivocal cases to undergo additional reflex testing. So if you start with a method, immunohistochemistry, and you get an equivocal result, you reflex to FISH and vice versa. The other requirement that's important to know about is if you have a specimen that doesn't meet the technical specifications that have been set forth, meaning fixation in 10% neutral buffered formalin, fixation for the appropriate length of time, and limited cold ischemia time, you may want to test an additional specimen on that patient. And we have criteria for single probe in situ hybridization assays, which are available and FDA approved, but less commonly used, in which you would simply just count the number of HER2 gene signals per nucleus without ratioing to a control probe for chromosome 17. So 4 to 6 gene copy, HER2 gene copy per nucleus in that study would be an equivocal result. Greater than 6 would be positive. And then in the dual probe assay, which is more commonly in use and the one that we use here, ratio greater than 2 with a HER2 gene copy number greater than 4 is considered positive.
So she's in your clinic now.
So I guess to summarize, Jamie, it sounds like we have a woman who's 39 years old with a clinical T3N0 breast cancer. That would be a clinical stage 2B. And after examining this patient, we would consider the following things. One would be a metastatic workup, and that could include either a PET scan or a CT, chest, abdomen, pelvis, and a bone scan. We'd like to exclude metastatic disease because it might influence our treatment approach in this patient. The other thing we would commonly do is refer the patient for a genetic evaluation based on her young age. Although the family history is not particularly concerning, premenopausal patients in general are referred for genetic counseling in our program. So I think that would be an important part of her evaluation, so we would do that. At the present time, it looks like, based on the imaging studies, that the patient has a multicentric breast cancer. I would like to emphasize that I would make that assessment primarily based on the mammogram, and it appears based on the MR that there is a second lesion, and if there was any doubt about that in treatment decision, we would ask for a biopsy to be performed of that second lesion. But I think given the extensive nature of the disease in the right breast, we could assume it's multicentric. In that case, traditionally, a mastectomy would be the operation of choice. With a mastectomy, we would also perform a sentinel node biopsy. I would say that would have been our approach 5 or 10 years ago, and with recent changes in the medical oncology approach to patients with HER2-positive disease, we at the present time see these types of patients in our clinic in a multidisciplinary fashion and would make decisions about whether to start with chemotherapy or surgery in consultation with a medical oncologist. And then we would work together to formulate a final treatment plan for her.
So the reason you're thinking about neoadjuvant chemo is it the age or the ERPR or HER2 or the size, or is it all together? Or?
Well, I think the primary issue in the medical, the medical oncologist can speak to this better, but is the efficacy of the new combinations of drugs that we have that are available for patients in the preoperative setting only. And I think the very high complete response rates that we're seeing with that type of treatment, although in this case I don't think it will influence the type of surgery that we required, it may actually facilitate our approach to a mastectomy, which will be her ultimate operation. It, in addition to providing a high chance for a complete response, which we think is associated with a good long-term outcome, may make the technical conduct of the surgery easier in achieving complete margins. So I think there's several reasons why we would strongly consider neoadjuvant therapy in this case.
And do you want to see this patient at this time, or do you usually do that? Or?
I think from a radiation oncology perspective, it's very important to see these patients up front at the time of multidisciplinary consultation, as we routinely do here. The importance is that in patients who are receiving preoperative chemotherapy, there's not a lot of good data regarding indications for requiring post-mastectomy radiation therapy. So a lot of that depends on the clinical judgment and staging at the time of initial presentation, as well as assessing the response to therapy. So it is very helpful to assess the patient at the beginning prior to any definitive therapy.
Right. So she's back in Hailey's clinic, right?
In terms of the decisions that we make together about doing chemotherapy preoperatively versus waiting till the adjuvant setting, we have a number of very good studies showing that the efficacy in terms of overall survival to chemotherapy is equivalent whether you give it in the preoperative setting or in the postoperative setting. So situations in which we would not want to do preoperative chemotherapy include cases where perhaps it's a patient that ultimately won't require chemotherapy, or if the surgical staging and those findings would influence our choice of systemic treatment. I think if it would be helpful for the surgeon, we're always happy to give adjuvant systemic therapy up front, particularly in patients with histologies like this, hormone receptor negative, HER2 positive. Virtually all of those patients, unless they have an extremely tiny tumor, are going to be recommended to have adjuvant systemic chemotherapy, and for HER2 positive patients with HER2 directed therapy. Until very recently, our choice of chemotherapy was really the same whether we gave it in the preoperative or the postoperative setting, and so that really didn't play into things. However, we're now in a situation where we have a new drug called pertuzumab that was approved in combination with taxane and trastuzumab-based chemotherapy in the preoperative setting. So this patient actually was recommended to have a combination of docetaxel chemotherapy with carboplatin, trastuzumab, and pertuzumab, which is the regimen that we have kind of chosen as our preoperative regimen for HER2 positive patients here at the Cleveland Clinic.
So if you look at the NCCN guidelines, it talks about many different regimens in neoadjuvant setting. So why do you choose TCHP or
So for the most common regimens that we use in the adjuvant setting include anthracycline, such as 4 cycles of doxorubicin and cyclophosphamide, followed by taxane, such as weekly paclitaxel for 12 cycles in combination with the trastuzumab, or the similar combination of docetaxel, carboplatin, and trastuzumab. We know that there is an increase in cardiac toxicity risk when you combine both the anthracycline and the HER2-directed treatment, and as we get more and more effective with our HER2-directed regimens, we probably don't need the anthracycline as much. So among the choices that the NCCN lists, we've really decided to uniformly use this regimen for most patients. The NCCN guidelines all kind of lump together their neoadjuvant and adjuvant treatment recommendations for HER2 positive, and they list the anthracycline and taxane or carboplatin taxane chemotherapy regimens, and then actually make a notation with or without pertuzumab. And I just want to note that we really don't yet have the long-term data in terms of survival on these studies. So right now, we're not routinely giving pertuzumab in the adjuvant setting, but we have begun using it in the neoadjuvant setting, where it does appear to improve pathologic response rate and therefore should improve operability. I think one needs to be up front from the beginning what our goal is of the neoadjuvant therapy. And if it's simply to make it easier for the surgeon to get around it, to get negative margins, but still a mastectomy is going to be recommended, we need to know that up front, versus if the patient thinks that we're going to have breast conservation as a result of the chemotherapy first.
James, traditionally we used neoadjuvant therapy primarily to downstage tumors, so patients with T2 or T3 tumors who were desiring breast conservation, we would use neoadjuvant to shrink the tumors down and make the candidate a patient for neoadjuvant therapy. I'd be interested in Hallie's thoughts on this. It was my understanding that the use of the new agents for HER2-positive breast cancer led to a higher pathologic complete response rate, and for many subtypes of breast cancer, we have traditionally associated a pathologic complete response with an overall better outcome. So I'd be interested in your thoughts on that.
Well, it is correct that a pathologic complete response is associated with a better outcome. The problem, however, with using pathologic complete response as a surrogate for choosing which regimens to use in the neoadjuvant setting is that while those patients that achieve the pathologic CR do better, those patients that received the regimen resulting in the higher pathologic complete response rate haven't necessarily shown a survival advantage simply from having received that regimen. So the probably best example of that was the NSABP B27 study, which was not limited to HER2 positive patients. This was a study in which patients were randomized to receive doxorubicin and cyclophosphamide chemotherapy with or without docetaxel. And while the addition of docetaxel significantly increased pathologic complete response rate, it did not alter survival in the patient population studied. A similar finding in the NEO-ALTO study, which was recently presented, looked at HER2-positive patients with operable breast cancer, and patients all received HER2-directed therapy, either trastuzumab or another drug called lapatinib versus a combination of the two. Again, the combination therapy resulted in a significantly higher pathologic complete response rate, but once again, no difference in overall survival. Now, we're hopeful that those results will be different with the addition of pertuzumab, and I believe part of what led to its approval was that we do have evidence in the metastatic setting, in the first-line treatment of women with HER2-positive metastatic breast cancer, that the addition of pertuzumab to docetaxel and trastuzumab treatment significantly improved survival, and those results were just recently updated with about close to a 16-month survival advantage. So that additional data in a different setting is highly encouraging that this would likely translate into a benefit. But the FDA approval was conditional, and we do await the survival data from the studies upon which the FDA approval was granted.
So the FDA approval is based on Neosphere and Trifina, right?
Yes, those were the two main studies. So the Neosphere study was quite similar to the Cleopatra study, which was in metastatic breast cancer, looked at docetaxel chemotherapy and trastuzumab with or without the addition of pertuzumab. That study also had a third arm of just the biologic, the trastuzumab and pertuzumab. In that study, there was an increase in the pathologic complete response rate with the addition of pertuzumab to the trastuzumab and docetaxel regimen. The biologic treatment only arm did not do as well. That's very impressive data in terms of the added benefit to the pertuzumab, but that's not really a standard regimen that we use in the adjuvant or neoadjuvant setting. So the Trifina study looked at regimens a little bit closer to what we routinely would use. So in the Trifina study, more standard type neoadjuvant or adjuvant regimens were used. In arm A of that study, they used FEC chemotherapy, which is 5-FU, epirubicin, and cyclophosphamide, followed by docetaxel chemotherapy in 2 of the arms. In all arms of the study, the recipients got both trastuzumab and pertuzumab. In arm A, the biologics were started with the FEC chemotherapy and continued throughout the chemotherapy. In arm B, the FEC chemotherapy was given without the biologics, and then, as we more typically do, the monoclonal antibodies were added along with the taxane. And then there was a third non-anthracycline arm, which was the docetaxel and carboplatin arm, similar to what this patient got, and again with the trastuzumab and pertuzumab being given from the onset. And so in this study, all arms got both trastuzumab and pertuzumab, but all arms had very high pathologic complete response rates, ranging from about 57% to about 66%. And that was the TCH arm that had that very high pathologic complete response rate. So there was no evidence, at least in this randomized phase 2 study, that the anthracycline added in terms of efficacy, and from our trastuzumab studies we know that it would increase the risk for cardiac toxicity. So this is part of our rationale behind choosing this regimen for our routine use.
Right. So what are the side effects from this then? What do you see in the clinic though?
So we see typical chemotherapy type of side effects: myelosuppression, nausea, vomiting, alopecia. With the addition of the pertuzumab, there does seem to be more diarrhea than we are used to seeing with typical TCH type regimens. We're also seeing more rashes with that combination.
Right. I think diarrhea is the one which I noticed more, and then you're right. And are you using Neulasta with this regimen? Or?
We have routinely been using Neulasta because it is a pretty myelosuppressive regimen.
Right. And cardiac toxicity, we do the same routine the follow-up. So when do you send the patient back to surgeon? How often you do that, and after how many cycles usually you do that?
It's a little bit surgeon dependent, but in general we try to send the patient back about halfway through the chemotherapy regimen so that they can be reassessed and have plenty of time to arrange surgical planning. Oftentimes plastic surgery is involved in these patients, and so they may need some extra time for scheduling.
Right. And what do you routinely recommend, mammogram or MRI? What do you do when in
Well,
the
there's some
midway?
controversy, obviously, about the best way to assess response to neoadjuvant therapy. I would say the most common technique we use still at the Cleveland Clinic is MRI, and we think it gives us the best indication of how patients respond. In some parts of the world, ultrasound is also commonly used. So we like to see the patients back about a half to 2/3 of the way through the chemotherapy treatment, as Hallie mentioned. The primary reason is to make sure that they are responding in a way that we like to see. Also allows us to begin to check on the patient relative to their genetic status, because that might influence the surgical decision making. Allows us also in patients who are considering mastectomy to get the plastic surgeon re-engaged at that point. Often the patients will have many questions about the type of reconstruction, the timing of reconstruction, and even for us, the surgical approach. And seeing the patients around that time gives us plenty of time to work with the patients to schedule their surgery in a timely fashion after the completion of their neoadjuvant chemotherapy.
Laura,
And
do
I
you have-
think Steve is absolutely correct, and that in the vast majority of cases, we will do a post-chemo MRI. But I think in those patients who are contemplating conservation, it is important as well to get a mammogram and/or ultrasound, so that for localization purposes, when the patient presents on the day of surgery and we're going to place wires, we know what we're dealing with in terms of tumor response, what things look like. And you'll see in this particular case, we did do a post-chemo mammogram, and I can sort of speak to why that happened.
So,
Well, I'd like to review the imaging already had.
Right.
Yeah. This patient clinically had a very nice response
Okay.
in terms of her palpable abnormality.
okay.
So these particular images, the one in the top left corner is the MRI that was performed 2 months into her chemo regimen. The one in the bottom right corner is her initial pre-chemo, right after diagnosis, that MRI. And you can see, again, from the pre-chemo MRI, she had a large area of enhancement involving nearly the entire upper inner quadrant of her right breast. She had a second area that was highly suspicious in the inferior part of her breast. And on this maximum intensity projection image, you see no enhancement in the right breast, which would indicate tumor response. When you look closer at these, though, these are the T1 axial subtracted images. So they do a pre-contrast image, and then they give contrast, and then subtract the two. Anything that's enhancing technically is suspicious. In the top left corner, you see that there is still residual enhancement in the upper inner right breast. The lesion in the inferior breast is also still present, although they were much smaller in size. This, as I mentioned earlier, there was a mammogram performed after chemo, and they were really looking to see if there was tumor response within the breast in terms of the calcifications. And you can see there are fewer calcifications compared to the initial mammogram, but she has not had complete response from an imaging standpoint.
Right, so what's the sensitivity and specificity of MRI in this setting, or even at screening setting?
Well, okay, so the MRI, there's a lot of false positives in MRI. So lots of things show up because there's hormonal influences on the breast tissue, which is part of the argument as to why MRI isn't always so beneficial, because then you're obligated to go chase these findings, and it sets the patient up for a lot of 6-month follow-ups, MRI biopsies that may not otherwise pan out to be anything. As far as assessing tumor response, the sensitivity and specificity is actually very good. MRI does not have a lot of false negatives, but DCIS certainly is one scenario where MRI doesn't do as great a job as an invasive disease.
But we still clearly see patients who have a complete response after chemotherapy
Yes.
on MR and still have some foci of residual disease. So we're not quite to the point where we can say, based on the imaging, we don't need to do surgery. Maybe one day we will, but not now.
And I mean, I think that's exactly right, Steve, in that, you knock out the tumor enhancement, you're knocking out the blood supply to these tumors. It's not to say it happens 100%. The resolution of MRI isn't as good as mammograms. You cannot say, that's why we try to be very careful and not say the tumor is completely gone. We just say that there has been response. There's decrease in the enhancement, which would indicate that there's been a good response.
But that's going to definitely help you in having the conversation with the patient about surgical options.
Sure. And particularly in patients who are desiring breast conservation, we think it's pretty critical in helping make decisions. And the other thing I would emphasize, and Laura mentioned it earlier, is when we first evaluate these patients, we do need to make sure that there's a clip which is left in the tumor, because with modern neoadjuvant therapy, in many cases we see these complete responders in patients who, even in whom we're going to do a lumpectomy, we need to know exactly which area to go back into to remove. So we, at our initial visit, do check to make sure that's been done.
So now she's back in your clinic and she had the chemo and she has an MRI.
Yes, and it looks like based on the MRI study, she's had a good response to the treatment. This is a patient who I think from the outset we had discussed, or we would have discussed, because of the multicentricity, the role for a mastectomy in this setting. And in fact, that's what she, I think, agreed to in this case. This is a case with a good response like this. We'll do often operation in conjunction with our plastic surgery colleagues. At the time of the mastectomy, we will perform a sentinel node biopsy, and we'll do that to, we believe that in the neoadjuvant setting that sentinel node biopsy is accurate. At the time of doing the sentinel node procedure, we do carefully inspect the exome to look for other suspicious nodes. The type of reconstruction is always a discussion point in our practice, most commonly in patients who may need radiation therapy after their mastectomy. We will, in patients who are desiring long-term breast reconstruction, we'll place a tissue expander at the time of the mastectomy.
Her BRCA testing came back as negative, right? She was BRCA negative. And then her surgical choices were...
This patient chose to have a bilateral mastectomy, and that is obviously a topic of great discussion these days. I would say the way we approach patients who are desiring prophylactic, what we call prophylactic contralateral mastectomy, removing a non-diseased breast, is that we tell them what we know about that, and it's pretty clear that removing normal breast in a patient without a known genetic mutation has been shown to have very little impact on their overall survival. And so we do spend a lot of time counseling patients about that. But I would say, in spite of that, in our practice, and I think in many practices around the country, particularly in young patients like this, there are other factors which drive patients to want to have the prophylactic mastectomy. And I think it's primarily fear over another recurrence in the breast, fear of having to be told that there's something else in the other breast that needs to be biopsied. And I think that's a large driver. But we do spend a lot of time with patients, and we don't take that decision lightly, and we certainly don't, it's not something we routinely recommend to patients in this setting. But this is a patient who did choose to have that done.
So is MRI playing a role, or genetic testing playing a role? What, I mean, I know you just mentioned that there's a substantial increase in bilateral mastectomy. And
I think MRI is playing a role. I honestly do. Because there are so many false positives in MRI, lots of other lesions show up. And then the patient is then on this train of follow-up. We're either doing 6-month follow-up MRIs, and that can be very anxiety-provoking. Even setting the patient up for an MR biopsy, that's not without its own risks. It's another dose of contrast. You know, it's a pretty sizable needle. Patients are uncomfortable doing those studies. I think the big driver is the anxiety of it all. Mm-hmm. That is the big player. You know, particularly young patients, as Steve mentioned. I don't think patients want to ever hear the word cancer ever again in their lifetime. So they want to just hit this tiny little thumbtack with a giant hammer and reduce their chance of it coming back ever again.
So when you talk to the patient, when you counsel them about contralateral breast cancer, I don't know, what will you say? What's the risk? Well,
a patient without a known genetic mutation, we tell them that the risk is in the neighborhood of 0.5 to 0.75% per year for developing a contralateral cancer. And obviously, given that there's time in that equation, younger patients we think might be at greater risk, but it's pretty well established that one of the primary risk factors for developing breast cancer is a personal history of breast cancer. So we're pretty transparent about all those facts. And I guess the other part of this is not a patient who will be on anti-estrogen therapy either for 5 or 10 years. So they may perceive there's no other defense for them going forward. So, but this is always a lengthy discussion and one that we don't take lightly. And particularly as patients can have complications from surgery, prophylactic surgery, we just need to have everybody on the same page as we make those decisions together.
Okay. So the patient had mastectomy, and we have the path, right?
We do. So there was no residual tumor identified in the mastectomy specimen. We did identify a fibrotic tumor bed with some calcifications, which may correspond to the imaging findings after neoadjuvant therapy. We evaluated 4 sentinel lymph nodes from the right axilla, all of which were negative for tumor. So pathologically, this patient is staged as a YPT0N0 based on sentinel lymph node evaluation. This is one representative image from her tumor board showing the findings that we see that are a tumor bed, showing the findings that are representative of treatment effect that we see in this setting, which is a fibrotic tissue background with lymphocytes, which you can see on the left side of the field, macrophages on the lower right, and calcifications in the tumor bed. And this is what we see in cases of a complete pathologic response.
So now the patient is back in your clinic. You're talking to the path report, and Rahul is going to pick up from there, right?
Yeah. So this patient who initially presented with a clinical T3 right breast cancer with a suspicious lymph node that was biopsied but was not found to be involved at the time of initial presentation, who then went on to have an excellent response and a pathologic complete response to the chemotherapy. This presents a dilemma for a radiation oncologist. We have randomized data that supports post-mastectomy radiotherapy for patients with locally advanced disease who have surgery up front and then receive adjuvant therapy afterwards, in which case there's a 10% survival advantage in 3 randomized trials done in this setting. Unfortunately, there are no randomized trials examining the role of radiation therapy after patients who receive preoperative chemotherapy and then have a mastectomy. Until now, the NSABP B51 trial is an open study that's looking at patients with N1 disease that's biopsy proven, who then have a complete nodal response, and patients are then randomized to receive radiation therapy to the lymph nodes or not. It is open for patients who have breast conservation therapy and they receive whole breast radiation versus whole breast radiation plus regional nodal radiation, as well as mastectomy patients who are randomized to no radiation at all versus comprehensive nodal radiation. So this will be a very important trial to try to answer the question of whether radiation can be omitted in some of these patients who may have some benefit. Until this study is completed, we rely on really retrospective data, largely from MD Anderson Cancer Center, as well as a combined analysis from the NSABP published by Dr. Mamanas a couple of years ago. Studies from MD Anderson demonstrate that in patients with a stage 3 presentation up front still derive a significant benefit in local regional recurrence reduction by post-mastectomy radiation, even in the setting of a pathologic complete response for these stage 3 patients. This patient was kind of a borderline between a 2B and a stage 3. Again, it's hard to know if that biopsy of the lymph node at the outset was a false negative or not. And so we have to make decisions in this case based on, as mentioned, the preclinical findings as well as the pathologic findings. In her case, factors that increase her risk of recurrence include her young age, ER-negative histology, the multicentricity, as well as the large size of the primary tumor, and again, that suspicious lymph node up front. The primary factor that would reduce her potential risk of recurrence include the terrific response to chemotherapy that she had. And we really don't have great data in the setting of some of these new regimens that result in a 60% pathologic complete response rate. We don't really have great data in this setting about which patients we can omit post-mastectomy radiation. So in her case, I did counsel her about the risks and benefits of going forward with treatment. And I think based in light of the number of risk factors that she presented with, I felt that she likely would derive some benefit from post-mastectomy radiation, probably a local control advantage, possibly a survival advantage, but again, that remains to be seen.
All right.
And a little bit more about the radiation fields. I mean, you give internal mammary nodes, supraclavicular, axillary, what is the?
So typically when we're treating somebody with post-mastectomy radiation therapy, we always cover the chest wall because that's the site of highest risk of recurrence. The second, based on patterns of failure, the second most common site of recurrence is in the supraclavicular lymph nodes. So we typically will always cover the chest wall, supraclavicular lymph nodes. Coverage of the axilla is dependent on the level of nodal involvement, but typically at least level 1 and 2 will be covered, at least the majority of that will be covered in the tangential fields. Internal mammary nodal radiation is very controversial. There has been one randomized trial from France that was a negative trial. However, we know that patients who are at the highest risk of having a internal mammary involvement are those with a medial tumor like she had, and in the context of axillary positive disease. So, I think we generally, if we're going to treat someone in this setting, I would certainly at least cover the chest wall and the supraclavicular lymph nodes and possibly the axilla.
And then, so Hallie just gave Herceptin and pertuzumab, and are you concerned about cardiac toxicity or?
So fortunately, this is a right-sided breast cancer,
Right.
so I'm not
Let's just say if
worried
it's a
about
left-sided.
toxicity in this case. We don't have any data to suggest that concurrent radiation with trastuzumab is unsafe. The trials that for which trastuzumab received its indication in the adjuvant setting did include patients who received radiotherapy, and there was not an observed significantly increased risk of cardiac events. That being said, obviously, we want to do everything possible to spare a patient's heart whenever treating the left side, and so we can use a number of different techniques, such as breath hold techniques and advanced technologies in radiation therapy to try to minimize the cardiac dose, because we've really observed that those things can make a difference.
So she had the surgery, and she already met with you, and she's back in your clinic for further follow-up and treatment.
So just as we would in the adjuvant setting, we would recommend continuation of single-agent trastuzumab to complete a year of therapy. We do have a clinical trial which wouldn't apply to her situation, but for individuals at higher risk by virtue of residual disease at the time of surgery after neoadjuvant anti-HER2-based chemotherapy. There is a clinical trial called the Catherine study in which patients are randomized to receive either standard trastuzumab, as we normally would to complete that year of therapy, or ADO trastuzumab emtansine, which is an antibody chemotherapy conjugate that is currently used in the treatment of metastatic breast cancer, but will be looked at for use in this adjuvant setting following neoadjuvant treatment with lack of complete response. So the ADO trastuzumab emtansine is basically trastuzumab to which a microtubule chemotherapy drug is bound, and essentially with the idea being that you would deliver the chemotherapy specifically to HER2-positive cells. And we know in metastatic disease that this drug is very active and the toxicity is very acceptable, and that's what has led to its the plans to study this drug in the earlier stages.
So Mikhail, thank you for joining us. Please tell us how ODAC came to a decision to approve pertuzumab in this setting. I know you were the chair of ODAC in this historical approval process.
So pertuzumab came before the Oncologic Drugs Advisory Committee, or ODAC, of the FDA under the accelerated approval mechanism. When we consider a drug for accelerated approval, we of course weigh the potential benefits of that drug with the potential risks of administering that drug. But the difference with accelerated approval as opposed to full approval is that we're considering an endpoint to a study that's reasonably likely to translate into a clinically meaningful benefit. In other words, for accelerated approval, drugs don't always have to have an overall survival endpoint. They could have progression-free survival or even response rates. For Perjeta, the confirmatory study or registration study that came before us was Neosphere, which is a multi-center randomized trial of 417 patients who were randomized to one of 4 arms of therapy prior to undergoing definitive surgery for their breast cancer. In other words, neoadjuvant therapy. Those 4 arms included trastuzumab plus docetaxel, pertuzumab plus trastuzumab and docetaxel, pertuzumab plus trastuzumab, or pertuzumab plus docetaxel. The primary endpoint of this study was pathologic complete response. What the study found was when comparing the arm of patients who received pertuzumab plus Herceptin plus docetaxel to those who received Herceptin plus docetaxel, the pathologic CR rate was almost 46% for those patients randomized to the pertuzumab arm versus 29% for those randomized to the arm that didn't contain pertuzumab. This represented an absolute difference in pathologic CR rates of almost 17%. And this was largely driven by patients who were ER/PR negative. So that's the good news of the study, and that is that the study seemed to work. It seemed to demonstrate that there was a difference in pathologic CR rate. We then weighed some of the adverse events associated with patients randomized to the pertuzumab arm. Those included grade 3 AEs, which were 73% for those who were on the arm that didn't include pertuzumab, to 63% to those who were on the pertuzumab arm, and SAEs. There were, however, higher rates of cardiac AEs, including left ventricular ejection fraction decline, on patients who received pertuzumab, and this was something that we considered carefully. Ultimately, we felt that the benefits outweighed the risks of receiving pertuzumab. We felt that the endpoint was likely to translate to a clinically meaningful endpoint. So, and that was based on a meta-analysis that was performed on almost 12,000 patients who were treated with neoadjuvant therapy, where it showed definitively that patients who achieved a pathologic CR were much more likely to have a better event-free survival and overall survival.
So, Mikhail, do you have any concerns about accelerated drug approval process based upon limited data?
So the accelerated approval mechanism is an interesting one. There are things that are conflicting when we talk about regulatory approval for drugs in the United States. You have a bunch of patients with cancer who are desperate for new therapies and desperate to get those therapies as soon as possible. What's on the other side of this is that we have limited data surrounding some therapies that are in earlier stages of development and don't necessarily know all of the toxicities that may evolve over time. So we try to balance those two forces, and the accelerated approval mechanism is the way that we balance them. When we invoke accelerated approval, what it means is that we're willing to accept the toxicities of a drug because the benefits of that drug outweigh those toxicities, and there's an aspect of this which requires a confirmatory study. That confirmatory study does have to have a more meaningful endpoint, such as overall survival, and has to validate the initial accelerated approval registration study in terms of its degree of benefit in its endpoint. So in other words, if you have an initial confirmatory or registration study that leads to accelerated approval that shows, for example, an advantage of a pathologic CR rate that's 17%, we would expect that in the confirmatory study, that advantage of pathologic CR rate of 17% for patients treated with Perjeta is maintained, and it translates into a more meaningful clinical endpoint, such as event-free survival or overall survival.
So, Mikhail, do you think this is a very unique situation, or do you think other drugs will be approved based upon neoadjuvant data in the future?
This was an interesting drug to come before ODAC for consideration of neoadjuvant therapy. This was the first drug approved for neoadjuvant treatment in breast cancer in the United States by the FDA, and we felt that this was a historic moment when ODAC unanimously agreed that this drug should receive accelerated approval. The reason we felt that was because we saw an advantage in the pathologic CR rate of 17%, and that we thought was meaningful. We also felt that that was likely to translate to a more robust endpoint, such as event-free survival and overall survival, because of a meta-analysis that had been performed on almost 12,000 patients. What was also reassuring to us is that the confirmatory study was 99% enrolled at the time we met. As of August of 2013, and we met in September of 2013, that study was 99% enrolled, meaning that it would be completed in short form with follow-up available so that there wouldn't be a long delay between accelerated approval and full approval, if in fact that confirmatory study did what it was supposed to do, and that is confirm the effect of the Perjeta that we thought that it would.
Terry, can you please go over the NSABP B50I or the Catherine trial?
The NSABP B50 and B51 trials are two randomized phase 3 trials that ask two important questions. The B51 trial asks the question of whether we can use the response to neoadjuvant chemotherapy in order to tailor locoregional radiotherapy, and the B50 trial asks the question of whether we can use response to neoadjuvant chemotherapy in order to further tailor adjuvant systemic therapy following neoadjuvant chemotherapy. The rationale for the NSABP B51, also known as RTOG 1304 trial, is based on observations from several randomized clinical trials of neoadjuvant chemotherapy that have consistently shown that achievement of pathologic complete response in the breast with negative axillary nodes predicts for excellent long-term outcomes, both in terms of locoregional recurrence as well as distant recurrence. Results from previous neoadjuvant chemotherapy trials, such as the NSABP B18 and B27, have shown that neoadjuvant chemotherapy does not only downstage the disease in the breast, but does so also in the axilla. Thus, with effective neoadjuvant chemotherapy, up to 40% of patients with involved axillary nodes and potentially up to 50% of HER2-neu positive patients that are treated with neoadjuvant chemotherapy plus anti-HER2 therapy are found to have histologically negative nodes at the time of definitive surgery. So with increasing use of neoadjuvant chemotherapy, a commonly encountered clinical scenario involves patients who present with involved axillary nodes, receive neoadjuvant chemotherapy, and are found to have pathologically negative nodes at the time of definitive surgery. For such patients, there is an active debate on the appropriate use and extent of locoregional radiotherapy after mastectomy or breast conserving surgery. On one hand, since these patients presented with non-positive axillary nodes, they are at high risk of locoregional recurrence and should receive comprehensive radiotherapy based on a wealth of data showing significant improvement in outcomes with the addition of post-mastectomy, chest wall and/or regional nodal radiotherapy, or post-lumpectomy regional nodal radiotherapy. But on the other hand, these patients are not negative after neoadjuvant chemotherapy, and sterilization of involved axillary nodes after neoadjuvant chemotherapy has been shown to lower the risk of locoregional recurrence, making the need of comprehensive radiotherapy questionable. This decision is further complicated by the desire for immediate reconstruction and the potential for increasing complications from reconstruction when radiotherapy is used. So, the major question that the B51 trial is trying to address is whether we can use tumor and nodal response to neoadjuvant chemotherapy in order to individualize the use of locoregional radiotherapy. To that extent, patients who present with T1 to T3 N1 breast cancer with proven axillary nodal involvement either by fine needle aspiration or core needle biopsy. They receive neoadjuvant chemotherapy, and if they are found at the time of surgery to have negative axillary nodes, and that can be either by sentinel lymph node biopsy, axillary dissection, or both, they are then randomly assigned to receive either comprehensive radiotherapy or not. For lumpectomy patients, the randomization is between breast radiotherapy versus breast plus regional nodal radiotherapy, and for mastectomy patients, the randomization is between no radiotherapy at all versus chest wall plus regional nodal radiotherapy. The primary objective of the study is to evaluate whether the addition of comprehensive radiotherapy will significantly reduce breast cancer recurrence in patients who present with histologically positive nodes but convert their nodes to negative following neoadjuvant chemotherapy. Secondary objectives are to evaluate whether the addition of comprehensive radiotherapy will significantly prolong overall survival, reduce local regional recurrence and distant recurrence, and to compare patterns of post-mastectomy reconstruction and the effect of radiotherapy on cosmetic outcomes and also quality of life following reconstruction. A total of 1,636 patients will be randomized. The NSABP B50 trial or Catherine trial asked the question of whether response to neoadjuvant chemotherapy can be used in order to further tailor adjuvant systemic therapy. Now, this is based on the observation that patients who do not achieve a pathological complete response after neoadjuvant chemotherapy have significant residual risk of recurrence, and the hypothesis behind the trial is that changing the adjuvant systemic therapy following neoadjuvant chemotherapy will reduce this risk. So patients with HER2/neu positive breast cancer who are found to have residual disease in the breast and or axillary nodes after neoadjuvant chemotherapy plus anti-HER2 therapy, and this can be single anti-HER2 therapy or double anti-HER2 therapy, either with trastuzumab plus lapatinib or pertuzumab, but T-DM1 is not allowed as a neoadjuvant chemotherapy regimen. And then the patients then are randomized to receive either trastuzumab for the remaining of 1 year or T-DM1 for the equivalent time period.
So Terry, what do you think about using PCR as a surrogate for drug approval process?
In 2013, the FDA for the first time granted accelerated approval for a drug in early stage breast cancer, and this was pertuzumab, based on data from neoadjuvant trials demonstrating increase in pathologic complete response over existing chemotherapy plus trastuzumab regimens. This approval is contingent upon future demonstration of significant improvement in disease-free and overall survival from either adjuvant and or neoadjuvant trials, some of which have already been conducted with this agent. This approval clearly paves the way for additional drugs to follow, and there are currently existing neoadjuvant randomized clinical trials that follow this FDA recommendation. This move by the FDA will undoubtedly lead to novel, exciting, and much-needed drugs becoming available earlier for breast cancer patients and solidifies the neoadjuvant therapy model as a nimble and effective way for developing and approving new drugs for this disease without having to wait for almost a decade for results of adjuvant therapy trials. And the FDA clearly should be applauded for taking this approach that will clearly advance our knowledge for breast cancer and the ability to bring drugs to patients.
So Terry, how do you explain the negative outcome of ALTO in this context, and what do you think about neoadjuvant clinical trial as a platform for drug development in the future?
The NeoAlto and the ALTO trials that have similar designs, only one is in the neoadjuvant setting, one is in the adjuvant setting, represent an opportunity to actually shed further light in this debate. So the NeoAlto trial compared the pathological complete response rates of trastuzumab, lapatinib, or the combination of both, given initially without chemotherapy for 6 weeks and then in combination with weekly paclitaxel for 12 weeks as neoadjuvant treatment for operable breast cancer. Per study design, following surgery, 3 more cycles of FEC chemotherapy was given and followed by the respective anti-HER therapy for the remainder of 1 year. In other words, either trastuzumab or lapatinib or combination. The primary endpoint of the NeoAlto study was pathologic complete response in the breast as per the NSABP definition. And the results of the trial, first presented in San Antonio in 2010, showed that pathologic complete response was 25% with lapatinib plus paclitaxel, 30% with trastuzumab plus paclitaxel, and 51% for the combination of lapatinib plus trastuzumab plus weekly paclitaxel. The PCR differences were not statistically significant between lapatinib and trastuzumab, but the PCR with a combination regimen was significantly higher than each of the single anti-HER2 therapy arms. Based on this PCR data, and given the strong association between pathological complete response and overall survival, the data from the ALTO trial, which was the adjuvant equivalent of the NEO-ALTO trial, were very eagerly awaited. However, when the results of the ALTO trial were presented at the ASCO meeting in 2014, there was no statistically significant difference in disease-free or overall survival with the addition of lapatinib to trastuzumab. So at first glance, these results seem to not be supportive of the hypothesis that increases in PCR will be associated with improvements in long-term outcomes, but on closer examination, I believe that these results continue to support the association between PCR and long-term outcomes. There are a couple of things to consider. First, other trials have not shown the same magnitude of increase in PCR with a combination of lapatinib trastuzumab over trastuzumab alone, particularly when anthracycline-based regimens were given in the neoadjuvant setting and not in the adjuvant setting like in the NEO-ALTO trial. For example, the CLGB 4601 trial showed only a non-significant 10% difference in PCR from 56% from 46% with the addition of lapatinib to trastuzumab plus paclitaxel, and the NSABP B41 trial showed a non-statistically significant 11% difference in breast PCR when lapatinib was added to neoadjuvant chemotherapy regimen of AC followed by weekly paclitaxel plus trastuzumab. Thus, the contribution of lapatinib to increasing pathological complete response when anthracycline and taxane chemotherapy is utilized as part of the neoadjuvant regimen is modest and concordant with the long-term effects of the ALTO trial. Furthermore, although there were no statistically significant differences with the addition of lapatinib to trastuzumab plus chemotherapy in the ALTO trial, closer observation of the hazard ratios demonstrates a small but non-significant trend towards some benefit, but given the statistical design of the study with the inclusion of the arm with sequential anti-HER therapies, this did not reach statistical significance. Such small differences in disease-free survival and overall survival could be compatible, though, with the small increase in PCR observed in the B41 trial as well as the CLGB 4601 trial. Thus, I believe that the results of the ALTO trial are still consistent with the hypothesis that increasing pathological complete response in the neoadjuvant setting, or lack thereof, correlates with disease-free survival and overall survival differences in the adjuvant setting, and again, or lack thereof, as was the case in the ALTO trial.
So Mikhail and Terry, thank you so much for joining us in discussing this important topic.